First, I want to thank you, every one of you guys, for being here today. We're team number 3, all represented with Invar. And our need findings is in surgery. So this is the agenda we're going to try to cover. So first, I want to talk about how our need find and filter process started. Well, it all started with the great opportunity we'll have through the introduce of Exo 619. We found clinical needs that were unmet. And after that, what just did was like focus on some of them and find some literature review. So when we look at the possible solutions from the literature review, we just watched some YouTube videos about how things are done. And then we sent emails to MIA surgeons, laparoscopy surgeons. We also wanted to focus on what's the opinions of patients. And we went through these forums that we said here. So we ended up with 40 needs, and we decanted it into 5 surgical needs. These were our 5 surgical needs. Have the examples that we previously learned is problem population outcomes. We wanted to focus in laparoscopy surgery with a population in our patients, and as an outcome, it was going to be a mix between patients and surgeons as well. So then we wanted to, well, let's try to put our findings into a grid and give them some points based on the factors that we don't know increase or not the likelihood of this need to be effective. And we ended up with our need number 5 with 87% of the points. Then we wanted to scope and down our need number 5. So we did 3 rounds of them, and we're still trying to focus on what's happening with laparoscopy surgery, but also what's happening as a medical problem was what's happening with the patient's hepatic pancreatic system. So we found a problem, and the problem is cholelithiasis, which is pretty much the presence of gallstone in the gallbladders of patients. And so far we know that 20 million people in the United States have cholelithiasis. And Canada, 20% of Canadian women have 10%, and 10% of men by the age of 60 will have cholelithiasis. And the way that this is fixed is through laparoscopy surgery. 300,000 are done in the United States, and 31,000 were done in Canada in 2019. Also important that we found is that cholelithiasis has a high incidence in our First Nation population. So now we have a problem with the disease. There's also a problem with the surgery. So the access into the abdomen poses a risk of continuous associated risk of injuries into the gastrointestinal tract, into the vessels as well. So we know 50% of the complications occur right after the beginning of the surgery. So this is the first step of the surgery, and we're already encountering a problem. So patients with cholelithiasis as well suffer from something called acute or chronic cholecystitis, which increases the presence of adherence tissues, which, as you can see here in the white circles, and this increases the chance of iatrogenic lesion during the surgery. So these are serious stuff, guys. So as you can see here in the white circles, so surgeons are going into the abdominal cavity without knowing what structures are in between the skin and the abdomen, and they can pierce a major vessel like this, and the likelihood of the patient will be at risk. So existing treatment exists, and we found a few of them. One is the saline drop test, which is after the surgeon inserts the reverse needle to create a pneumoperitoneum. They pretty much try to see if there's blood in the abdomen or not. Another one is the OPET technique with a Hasson trocar, which is pretty much a visualization direct into the abdomen to see if we're in the abdomen, in the peritoneal cavity. Some surgeons use shield trocar, as you can see in the white yellow tip on the bottom right, and others use optical trocars to pretty much see on live feed what the structures of the abdomen are going into. And some other surgeons use preoperative imaging, such as ultrasound or MRI.
Thank you, David. So after finding existing treatments, we searched for the existing gaps, and we found that the complication rate of finding the best entry point for laparoscopic surgery has remained the same during the past 25 years. And also, patients with entry complications will end up turning their surgery into open surgery, which is not a good thing. I will explain about that later. And also the peritoneal landmarks are the only acceptable method right now, but they're not actually really valuable after putting CO2 in patients' bodies. So finally, we found out that there are no clear consensus that for finding the best and optimal entry point into patients' abdomen. So we finally found our need to find a way to reduce the consequences of entry complications in patients undergoing laparoscopy cholecystectomy surgery in order to increase surgeons' operational precision. Our need must integrate into existing procedures that they're already using in OR, and also it should be painless, it should be MRI ultrasound compatible, and does not add any expenses into the system that they're using. And it would be nice if it's customizable, readily available, and easy to use for surgeons and residents. About the impact of our need on patients, it's that by finding the best entry point for laparoscopic surgery, the scars that they leave after surgery on their abdomen are reduced, and also they can get back to their normal life sooner. About the impact on surgeons is that they can move with more precision and also with more confidence, and we're also reducing the time for surgery so they won't get that much exhausted and tired. And about the impact on hospitals and public healthcare system, the total time for surgery will be reduced. So the time they're occupying OR room is reduced, and also they don't have to use too many troopers for a patient, and this is somehow another way that we're lowering the cost. About the market size in the US, we found the numbers for laparoscopic cholecystectomy surgery. And because if this method is the problem we're talking about isn't solved, they have to switch to open cholecystectomy surgery. So we also found the numbers for that. And you can see that there's a big difference between the cost for laparoscopy and open surgery. So if you find a solution, we can delete all these costs. And about the competitors, getting back to the slide of existing treatments that David talked about, we found 4 companies, we found 4 companies that they're performing these methods, but each of them had some kind of problem. So at last we did a little bit of SWOT analysis. The strength of our solution would be that it will reduce the consequences of entry complications. The opportunity is that it could be used also in other kinds of the surgeries, laparoscopic surgeries. The weakness is that because we want to find the best accuracy and find the optimal point, it would be a little bit of time consuming, and the threats is that surgeons might not be comfortable with the new method and it cannot integrate into other OR devices. So all in all, we want to find a way to improve the surgical outcomes of patients undergoing laparoscopic cholecystectomy. We want to reduce the incidence of entry complications and empower laparoscopic surgeons. And thank you, everyone.
Great, thank you very much. We can start with Professor Mahali.
Yeah, nice and fluid presentation. Very good. So, when you had limitations of the previous, of other techniques, which was well done, but what your need, I was lost whether it addresses any of those, because you had like must have, which parts does it address in terms of the previous?
Well, previous, the problem is that, and this is something that we were talking about to Frieda, is that if you bring in an ultrasound into the OR, you might, a Doppler ultrasound, you might have a chance to identify vessels before you're going in. But the problem is that once you put into the pneumoperitoneum, everything is expanded in the abdomen. So you might not be able to actually detect with more precision where the vessel is. But this is where the MRI solution might be compatible, if we think as a potential solution. But on the downfall is our patients will have a higher risk of having radiation, which shouldn't be something that is good for them. The previous treatments is that it is still based on the trocars. Surgeons are still debating which trocar is the best. Is it the shield one with the tip versus the one that allows you to see as you go in a monitor what are the structures you're going in. But the thing is that, yeah, you can go inside the abdomen with more precision, but if the tip it is still and a blade, you still have a risk of perforating something that as you can see from patients with cholelithiasis, have a lot of adherence in the tissues. You're pretty much blind inside the abdomen. Finding a solution, I think we think we have to include definitely some optical imaging, and we're trying to focus into that, perhaps with augmented reality solution, which allowed us to augment the visual field of our patients. But how can we integrate that into the already, because we don't want to add another instrument that the surgeon will have to be like, okay, this is another step, we have to do this, it's going to be more time consuming and so forth.
Okay, thanks.
Edna?
I think in my mind you're mixing up several problems, specifically about the problem of the location where to enter. Again, I would be interested in quantifying that problem.
Yeah.
Chole is the most common laparoscopy procedure, so most surgeons are extremely trained and familiar with this procedure. It's very, so I'm wondering why would you choose that as a problematic procedure, because it's very smooth.
Yeah,
And
most surgeons get trained.
I'm just saying comments, I'm not,
No,
you
no,
don't
no,
have
exactly.
time for answers.
Yeah.
The other thing is, differentiate. Are you looking for a solution to point of entry, or are you looking for a solution that will prevent hitting a blood vessel once you already entered? It's not the same problem.
We'll look into entry complications. So we're looking for avoiding perforating a vessel, perforating a bowel. That's what we're looking
Okay, so
for.
that's not the same as knowing from where to enter. That's one thing, and also you need to look into competition in the market because there are solutions for that already in the market.
Okay. All right.
At least for identifying blood vessels.
Any other quick comments?
Increase precision from what to what?
From creating an iatrogenic lesion in a patient. So you want to be more precise when you're operating, right? You don't want to encounter.
But how much more precise is meaningful?
Oh, that is that is a good question. I don't have the answer, to be honest. Yeah.
That-
Great, thank you very much.